Welcome friends, I am Dr. Ganesh Kulkarni, practicing pediatrician at Aurangabad, Maharashtra since last 15 years. Today we will be learning about a vector-borne disease, one disease that you will never want to happen to any kid on this earth. This is vector-borne disease. Malaria? No. Any cases? Dengue? No. Then another specific disease, probably this picture will give you an idea. This is a very common scenario in rural India where kids are playing in the water paddy fields and pigs and birds are in the close vicinity of it. So now you got the answer. This is how this particular disease has a potential of causing epidemics. This is how these kids, once get affected with this disease, will have a lifelong morbidity, and that is why this is Japanese encephalitis, a vector-borne disease. This particular disease is first time a case of Japanese encephalitis disease was found in Japan. That is why probably the name has been given as Japanese encephalitis. 1871 was the year when first this case was found. This particular disease is a mosquito-borne disease from a flavivirus family. The genus is the same as dengue and yellow fever. This particular disease is the most commonest cause of acute encephalitis syndrome. Now let us see why this particular disease is so important for public health per se. First thing is, it is epidemic. Periodic epidemics is a threat by this disease. Second is, it is in many pockets of India it is endemic. Then it has a high mortality rate, and as well it has a high morbidity rate, and moreover the specific treatment is not available. So that is why. Now coming to the epidemiology of this particular disease, primarily this disease is called as a disease of rural Asia. Here the vector mosquito proliferates in the close vicinity of birds and pigs. Birds and pigs being the maximum amplifying host for this disease. Culex tritanurhanicus is the vector which is the propagating disease, like Aedes aegypti in dengue and Anopheles in malaria. Now let us see how the global burden of this disease is. If you look at this map of world, you will see a red painted area, and this red painted area indicates that the Japanese encephalitis is very high risk in these areas, and you will find India has been painted in total red. That means this particular disease is endemic in many pockets of our country. Likewise, if you see that the red paint is there all over the Western Pacific region, all over the East Asian countries, so that is why almost 24 countries from Southeast Asia and Western Pacific areas are endemic for this particular disease. 3 billion people at a time live in Japanese encephalitis high risk zones. Around 68,000 cases and around 20,000 deaths have been found globally per annum. And coming back to our India, as we have seen, it is all painted red everywhere. Almost 215 districts from more than 22 states are endemic for this particular disease. To be very specific, 2013 almost 113 districts were endemic for this particular disease, while in 2017-18 almost 215 districts became endemic. So this disease is spreading rapidly in our country. More than 60,000 acute encephalitic syndromes are found in our country in last 10 years. Out of that, 10,000 were documented Japanese encephalitis. Actual incidence could be very well high, because we know that the poor surveillance and underreporting is very common in our country. Now let us see the footprints, how this disease is growing. Odisha is one particular state where this was actually non-endemic before, but in 2016 November we found a large epidemic happened there. Almost more than 1,000 cases were reported. Out of that, 115 deaths were found, and that was something alarming. This disease actually was meant as a disease of rural area, but to surprise all, Pune had documented 2 cases of adult documented cases of Japanese encephalitis happening. That also is something which is worrisome to us. Increasing endemicity, as I have told you earlier. Now what are the reasons? The changing monsoon climatic conditions probably is the reason. Increasing paddy field cultivation is again a reason to increase this disease. Coming to our India, these are the states: Assam, Uttar Pradesh, Odisha, West Bengal, Bihar, and Maharashtra and Haryana are the states which are large endemics for this reason. And specifically to Maharashtra per se, these are the districts: Gondia, Amravati, Bid, Nagpur rural, Washim, Yavatmal, Gadchiroli, and Latur. Government has already started routine JE vaccination in these endemic areas. Coming to this Japanese encephalitis transmission cycle, we all know that these mosquitoes, the vectors, they bite big pigs and birds. The virus when enters into these birds and pigs, amplify, proliferate there, multiply there, and once these mosquitoes reintroduce these particular viruses into humans, which are dead end hosts, this disease happens to humans. So this is what the greater risk is actually because of the rural areas where the close vicinity of these birds and pigs are common, and increasing rice field cultivation which is happening in certain districts, that also causes this proliferation. Now, which are the age groups which are really high risk, called as high risk age groups for JE? Most often these are the children between 1 to 18 years of age. More specifically, if you want to ask me, it is more 1 to 10 years of age group children are more vulnerable to this particular disease. But even not that, even we are finding it quite a lot happening in adulthood also. The reason being quoted as probably the improved vaccination happening, and this vaccination we do not know how many years this is going to give us protection. So that is one reason that it is happening in adults also and in non-endemic areas also. In non-endemic areas, adults are equally affected as the children. Now, how this disease affects humans? What is the pathogenesis of this particular disease? Incubation period of this disease is 5 to 15 days. This virus undergoes limited multiplication in host lymphocytes. Majority of the subjects or individuals eliminate this virus before entering into the brain by virtue of producing antibodies. These are the lucky kids, that's what I can say. JE virus can cause direct neuronal cell deaths, and it also can cause indirect neuronal cell deaths by proliferation of microglia and overactivation of inflammatory mediator cells. JE mainly affects thalamus, corpus striatum, brainstem, and spinal cord. Now let us see how it clinically presents. The course of disease can be divided into 3 main stages. First is prodromal stage. It lasts for 1 to 2 days, and it has high grade fever with rigors. Then we have headache, malaise, vomitings, and nausea, the insignificant symptoms. Second stage is perhaps the most deteriorating stage, and that is acute encephalitis stage. That lasts from starts from third to fifth day, and it has everything affecting the brain, that is altered sensorium, then it has convulsions, intractable seizures, focal neurological deficit, then it has change in the behavior of the child, probably it has other neurological signs like Kernick signs, neck stiffness, Brudzinski signs, everything coming positive. So that is most detrimental stage of this disease. And the third is late stage, that is what we call it as a stage of a sequelae, which starts from 6th day onwards. And in this stage, probably these so-called lucky children who do not get away with their life, but then they are crippled over lifetime, and that is the late stage, the sequelae stage. So schematically, if you want to ask me, this is the diagram which will give you the sinology and symptomatology. So from above down, this child has headache, nausea, vomiting, convulsions, then it has neck stiffness, pain in abdomen, muscle weakness, generalized apathy, and neurologically this child have convulsions, altered sensorium, focal neurological deficit. So these are the symptoms and signs commonly. Let's elaborate much more about the acute encephalitis stage, because that is the most important stage of this particular disease. This stage begins 3rd day to 5th day onwards. This has the first sign of this stage is altered sensorium, wherein this child, they are more lethargic, excessively sleeping, drowsy kids. The Glasgow Coma Scale starts worsening. Then we have high fever, changes in consciousness, as I said, convulsions which are focal seizures or generalized seizures. Then we have respiratory failure because of increased intracranial tension, Kusumal's breathing, that is what is popularly seen, and we have meningeal irritation signs like Kernick signs, Brudzinski signs. So these are the kids which you can see on the monitor, where this child is seen affected by this particular disease. Few facts about JE: probably 2 to 20 babies get affected out of 1000 gets infected individuals. They develop encephalitis, and out of these 20 babies who develop encephalitis, 20 to 30% they die. Remaining 70 to 80% will survive, but out of this 70 to 80%, 50% kids will be lucky not to get crippling disease or morbidity, but remaining 50% will have long-term morbidity. And what morbidity, in what form? They have motor deficit, they have mental retardation, they have convulsions coming again and again, they have speech disturbances, and they have secondary infections all as well. Now, which cases to be suspected to diagnose as a JE? So the diagnosis mainly depends upon every acute encephalitis syndrome case should be screened for Japanese encephalitis diagnosis, because as we know, every acute encephalitis syndrome is patient having high fever, altered sensorium with mental changes, and with or without seizures. So probably any child having acute encephalitis syndrome without having rash perhaps is a case of Japanese encephalitis. So mainly the child having absence of rash, altered sensorium, high fever, focal neurological deficit, then bang on, you probably are finding a Japanese encephalitis here. Now coming to the laboratory part. As we all know, isolation of virus is perhaps the main and most important way of diagnosing a illness. Second is demonstration of viral antigens, and third is finding genomic sequence. So these are the three different modalities, how the way we can diagnose this. Amongst all, the MAC ELISA is the most recommended test. Japanese encephalitis virus specific IgM antibody detection test is by MAC ELISA, and this is the most recommended test. Real-time PCR to find out the genomic sequence is highly sensitive and highly specific. So these are the tests. The cutoff for these tests is 4-fold rise in the serum antibody titers is the diagnostic criteria. Now there is a peculiar time to collect the samples for all these tests. For isolation of virus, first 4 days is very important. Likewise, for DNA PCR, also first 4 days collection of sample is very important. For IgM antibodies, 4 to 7 days after the onset of symptoms is very important time. We need to have 2 samples, one at the beginning of the disease and one towards the end, after near the discharge time or after 10 days of the illness. CSF is the most preferred sample over the blood, because in blood the antibodies may be present even without brain infection. Neuroimaging again remains the main diagnostic element. CT scan, you would find hypodense thalami, while on MR you will find hyperintense thalami. This JE mainly affects, as I said earlier, thalamus, basal ganglia, midbrain, pons and medulla. Movement disorders are more common in Japanese encephalitis. So this is all about the pathogenesis, clinical features and the laboratory diagnosis. Now let us see how we can manage these cases. And it is very rampantly known that all viral encephalitis syndromes, they do not have a specific management. They have supportive line of management. So here also the first and foremost thing, resuscitation of airway, breathing, circulation remains the mainstay of this disease management. Management of control of convulsions, management of intracranial pressure, control of temperature, fluid and electrolyte balances, management of nutrition, and general management and specific management for any other treatable cause, investigations, and mostly the most important part of it is reporting a case. Why we still have data which is lacking or is not supporting our JE statistics is probably it is underreported. So every case has to be reported. That is the main take-home message from this. And more than that, rehabilitation, because most of the cases have a long-term morbidity, they need rehabilitation. Now what are the preventive measures? 2 things we can do to prevent this particular disease. One is pig control and other is mosquito control. Now how do we do the mosquito control? It is a mainstay for preventing, in fact, dengue, malaria and all other vector-borne diseases. Outdoor resting habits, indoor control measures are very ineffective. Ultra low volume fogging is supposed to be very effective. and for pigs, isolation of pigs 5 kilometers away from the habitat, that is more important. But despite these two measures, it has been found that they are not the very effective way of preventing this disease. So what remains the most effective way of preventing this disease is the vaccination. So vaccination is very important. Coming to the vaccination now, what are the recommendations of IIP or ACVIP for JE, Japanese encephalitis vaccination? Routine vaccination is only recommended for the kids living in endemic areas and to the travelers who are traveling to the endemic area or to the epidemic areas. Government of India advocates Japanese encephalitis routine vaccination for all children in endemic area, 2 dosages. First dose at 9 to 12 months, second dose at 16 to 24 months. This is a live vaccine given only in government hospitals. Now, what different vaccines are available in Indian market, Indian scenario? So there are 3 different vaccines. One is, as I said, live vaccine, which is only available for government circulation. This comes in bulk from China. This is live attenuated SA 1414-2 vaccine. The other 2 are killed vaccines. One is varicose derived inactivated SA 1414-2 vaccine. This is popularly called as JIV vaccine. The other one is varicose derived killed vaccine based on 821564XY strain. This is popularly called as Genvac. The schedule of these 2 killed vaccines is, these vaccines are started from age 1 onwards. These vaccines are administered in intramuscular route. Genvac is a single preparation for pediatric and adult population, while JIV has 2 different formulations. One is 3 micrograms per 0.5 ml and the other is 6 microgram per 0.5 ml. The first 3 microgram per 0.5 ml vaccine is meant only for 1 year to 3 years of age group. For primary vaccination, the 2 vaccines 4 weeks apart. For 6 microgram 0.5 ml formulation, it is to be given only after 3 years of age. 2 dosages for primary vaccination, 4 weeks apart. So this is what. Now coming to the summary of this particular disease. So we all have understood that the disease has a high mortality, high morbidity. This disease is easily preventable by vaccination, and vaccines are easily available in our country. Only thing is we need to understand recommendations also. This vaccines is to be given only in endemic areas. If at all you want to vaccinate these kids, few conditions which are important. It is if the kids stay in an ecologically conducive area, or if you have found the vector of this particular disease available in your area, or you have seropositive cases of Japanese encephalitis documented in the area in the vicinity area of the kids where they are staying. So that is recommendations where you can give this vaccine safely. Save me is the cry coming from these kids. So let us eradicate this disease by effective vaccination in recommended areas. Thank you so much.